Morning guys, Dr. Dillard here. It is week 9. We're talking about dermatophytosis today, which is an important, very common problem in the human. It is dermatology, it's week. What is it, week 9? I already said that. Winter 2021. Here we go. We'll hit a couple nail conditions too. Longitudinal ridges and beading we should talk about. So these are normal conditions. This is not indicative of any type of disease at all. They're very common. The longitudinal ridges are just ridges running down the nail that look like a bunch of little grooves. I actually have these myself. They are seen in older people who are getting old, occasionally in younger people. I think in my 50s I started getting these things. And then beading is another one. That can occur at any age. I don't actually have any of that. Here's my nails, look exactly like this. So these are longitudinal ridges. They're kind of grooves, hills and valleys that run longitudinally, kind of perpendicular to the bones, the phalanges. And then I couldn't find one of pure beading, but here's beading, where it kind of looks like little beads of water on top of the longitudinal ridges. So this person has both of these conditions. Now, what is not normal are Beau's lines. Kind of a weird way to pronounce that. Beau's lines, like the headphones, Beau's headphones. So these are not longitudinal ridges and depressions. These are transverse ridges and depressions that show up somewhere in the nail. It doesn't have to be right in the center. They run, you could say, they run perpendicular to the nail plate. They're caused by a temporary disruption of mitosis. Remember, onychocytes are produced in the proximal part of the nail, underneath the nail bed in the matrix. And some severe stress can knock out the stem cells or cause them to stop working. And so you basically, for a week or two, you don't produce any nail. And that, as it grows forward, when the stem cells start working again and making onychocytes, it pushes that area that didn't, that area of kind of weird onychocytes or no onychocytes, it pushes it forward and it starts to show up in the nail as an area, kind of a dead zone, if you will. It takes about 2 weeks for it to show up. And there it is. See them right there? So. And when they're in all the nails, you could tell it was a big systemic type event, opposed to a specific trauma of a nail. So the stem cells here that produced the onychocytes, the nail plate cells, it died for a while, but then it came back to life and started making cells, and these are all new cells. So the matrix is working again. But this is the spot where the trauma occurred and the stem cells stopped working, basically. And that'll grow farther and farther, right? And pretty soon it'll grow right off the edge because new onychocytes are being made and pushed forward and forward and forward and forward. It's like the skin replaces every 23, 24 days. The nail takes a lot longer to replace, but it'll slowly move that way. Only the replacement cells push this direction as opposed to coming out of the plane of the page at you. Okay, there's some more examples. All right, so if you have multiple Beau's lines showing up, it indicates multiple disruptions. So pretty much everything I said. They move forward. If all of the nails are affected, it's a systemic problem that's occurred. If just one nail is affected, it's probably trauma to that finger that kind of stunned the stem cells under the nail plate. Took a while for them to come back online. What are some of the possible causes of these Beau's lines? Mechanical trauma, so having a really rough manicure, or getting your finger stepped on or closed in a car door. Dermatological conditions, like some of the eczematous diseases can do it. Diseases that can spread into the matrix and irritate those stem cells. Very severe stress events, that all of your fingers and toes would be affected, but a major stress, fractured femur, getting COVID, ended up in the hospital, death of a loved one, loss of a job. Diseases that cause high fever are also notorious for causing this. About 2 weeks after the disease has passed, they show up in your nails. So the viral pneumonia, respiratory type infections, both upper and lower respiratory tract infections, GI infections, gastroenteritis, urinary tract infections, scarlet fever, mumps, measles, cancer, could be an early indication of cancer, inflammatory diseases like rheumatoid arthritis, giant cell temporal arteritis, which we talked about with amaurosa fuga, remember that word? Systemic lupus erythematosus, amaurosa fuga is shade-drawn blindness. We've already talked about that a lot. There's a nice close-up of these. Okay, other kind of oddball diseases, syphilis, not so oddball, uncontrolled diabetes in some patients, myocarditis, inflammation of the myocardium of the heart, peripheral arterial disease is associated with these. So sometimes it's kind of, PAD is a very common type problem. Diabetes is a very common type problem. So then there's drugs. Cocaine can do it. Some of the antipsychotic drugs, amphetamines, penicillin. So there's a lot of things that can cause these. Some you can fix by stopping the penicillin or stopping the cocaine. Some of them are difficult. Like if you have rheumatoid arthritis, what are you going to do about that? All right, let's talk about the dermatophytes. The dermatophytoses are diseases caused by dermatophytes. These are the classic AKA for these is ringworm. Terrible word. It's got nothing to do with a worm. These are a group of skin. The dermatophytoses are skin conditions and nail conditions and hair conditions that are caused by an invasion of a dermatophyte, which is a fungus. Yep, that's what it is. So these fungi all have one thing in common because there's all kinds of different types of fungi. These fungi eat keratin, and we know that they eat hard and they eat soft keratin, but we know that keratin lives in the cells of the skin, the epidermis, and it lives in the nails as well. And so you get an invasion of the epidermis or nail plate, and that sparks an inflammation. And these little bugs are tough to get out of the skin. They can stay in that upper layer just underneath the stratum corneum and live there. And as the cells are ratcheted up and die, they just keep burrowing deep. But they don't burrow deep enough to go into the dermis, where of course the body's immune system lives. Right? They would be destroyed then. So they're smart. They stay right under the corneum where there's no blood. And it's hard to get rid of these things, especially when they get into the nails. So again, the word ringworm, which is a very common word for these things, has nothing to do with a worm infection. Again, they're caused by a fungus. Some call it a ring fungus, a dermatophyte. And the most common of all these dermatophytoses is one called Tinea Pedis, and that's athlete's foot. We will take a look at that one. Dermatologically, how would you describe the lesions? They can be eczematous in nature. Remember we said eczema is a skin rash. It's a single lesion. It's red. It can be crusty. It's itchy. Maybe scaly, maybe excoriated, where you've scratched it and caused it to bleed and it scabbed over. That's an eczema. So this can present eczematous. Therefore, it's erythemic, it's pruritic, which means itchy, erythemic, which means red, and it's scaly, which means scaly. But it's sometimes it's not like the classic erythemic eczematous lesion. It typically presents with this active border. So you get a lesion that looks like this, but the border is really crusty looking. I'll show you a picture of it in a minute. But in the center of it here, it doesn't really it almost looks like it's not that bad. So you look for that active border, and then you look, of course, some of the common places where it occurs. But see what I mean? Here is a Tinea corpus, and you can see that this is the whole lesion is here, right? And it doesn't look so bad in the middle. It's like it's healing here, but where it's spreading outward, you have that scaly redness, and yeah, that's Tinea corpus. We'll look at the different types of these diseases. It almost looks like the bottom of the foot, but because of this right here. But this is definitely a ringworm infection. How's that? Dermatophytes. So to be a dermatophyte, you have to eat keratin. If you don't eat keratin, you're not a dermatophyte. There are many different classes of these, or genera. That's the word for classes. Three big ones are Microsporum, Trichophyton, and Epidermophyton. Those are the three big ones. T. rubrum is the star of the show. There's actually different strains of T. rubrum as well. There's some that like to live under the nail plate, and there's some that like to live in the epidermis. We won't go that far into the weeds on this thing. But yeah, they get under the skin, they eat keratin, they live there, they multiply, and yeah, that's the story. They live in hair, skin, and nails. There are 10 main species of these dermatophytes in all three of the genera, and they all can cause dermatophytosis. There's actually 30 more classes of these things that occasionally can do it, so sometimes it's not so easy figuring out exactly which bug it is. But the T. rubrum is the most common of all these dermatophytes. Every single disease I'm going to talk about, dermatophytosis, I'm going to talk about is T. rubrum is the number one suspect. But again, we're not going to get into the different types of T. rubrum. That's pronounced trichophyton rubrum, if you're wondering how to pronounce that. How do you name a dermatophyte? Well, you start with the word, if it's fungi eating and it's on the skin in the usual spot and you suspect it's a dermatophyte, or if you get it histologically sampled and tested, it's always named Tinea at first. Tinea. And Tinea means it's a keratin-eating dermatophyte. And then you add to Tinea the location of the body where it is. So let's look at some of these. So if it's around, if it's on the bottom of the foot or between the toes, it's Tinea Pedis. Right? It can even be around the sides, like a moccasin, around the sides of the foot, or the hand, the palm of the hand, between the fingers. Tinea. So it's a keratin-eating fungus. Pedis means it's on the foot. If it's on the hand, they still call it Tinea Pedis. If it's on the front of the hand, if it's on the back of the hand where the hair is, it's Tinea manum for hand, mono for hand. Okay, if it's on the body anywhere else, like if it's on the back of the foot, on the dorsum of the foot, it's called Tinea corpus. If it's on the forearms, it's Tinea corpus. If it's on the belly, it's Tinea corpus. If it's in the groin area, it's called Tinea cruis. Tinea cruis, or jock itch, or jock rot, some of the slang names for that. Infection of the back of the hand, again, is specifically called Tinea manum. Why they didn't name one on the back of the foot? Why you don't call that Tinea manum? I don't know. But that's kind of a weird area there. If it's on the back of the foot, it's Tinea corpus. If it's on the back of the hand, it's Tinea manum. It's on the front of the hand, on the palm of the hand, then it's Tinea Pedis. If it's on the scalp, it's Tinea capitis. If it's in the beard, it's Tinea barba. If it's in the nail, it's Tinea unguium. Usually if it's in the nail plate or in the nail bed underneath the nail, it can be on both. It's usually called Onychomycosis, but an AKA is still Tinea unguium. Okay, a little more kind of fun facts about the Tinea corpus, the one that lives in the epidermis skin. Again, it penetrates just below the stratum corneum and lives there. And as the keratinocytes are ratcheted out and fall off, it burrows in deeper and deeper. But it doesn't go so deep to get into the dermis. It stays away from that. What helps it cut through the keratinocytes? It does produce an enzyme, this particular species of T. rubrum, called keratinase, that helps it cut through between the keratinocytes. It also has some immuno-inhibitor substances that it releases to, if it gets close to the dermis, and some of the body's white blood cells, Langerhans cells and such, can start grabbing and destroying it. It has some chemicals it can kind of squirt out and fight that. Some of the pathophysiology of certain species of T. rubrum, it decreases the speed of keratinocyte proliferation in some studies. This is not true underneath the nails though, but it's in the rest of the skin it's true. We don't know the mechanism of that yet, but some studies show that it turns the normal 25 to 30 day turnover way down into maybe half of that, 12 days. So that way it's easier for it to stay put and doesn't have to keep burrowing in as the keratinocytes keep kind of moving out, sloughing off and dying. Okay, onychomycosis. So that is the Tinea unguium, or tinea of the nails. A very tough condition to treat depending on where the nail it is. I have this problem, and I stand for dermatology. I can tell you what they have to say about this, as well as what the research says. So it's a dermatophyte infection of the nail plate and or nail bed. It can be underneath as well. The fingernails are less affected. The nails are 90% of the time. That's where mine is. And it starts out as Tinea Pedis oftentimes, and then spreads into Tinea unguium, or Onychomycosis. It is a tough condition. Even my Stanford dermatologist said there's not much we can do about it. It doesn't hurt or anything. It's just kind of gross looking. Mine's on my baby toe, on my fifth toe, and on my first toe I'm starting to get a different type of it. So I have two types of it going. One is treatable, one's not. But it results, I don't have this type, but some of these can result in a subungual, meaning under the nail, hyperkeratosis. And strangely, unlike the Tinea corpus type of T. rubrum, this type actually speeds up the keratinocyte proliferation. And that little modified skin that lives underneath your, that is the nail bed. Remember, the nail bed is underneath the nail plate. That's the hard part of your nail. The keratinocytes, the dead keratinocytes, can start to pile up, and your nail can get really, really big and gross looking. We'll look at some of these. Mine don't look like any of these things that we're about to see. So you have to be careful with psoriasis, because psoriasis can do the same sort of thing. T. rubrum again, T. mentagrophyte is another common one. Both of these cause onychomycosis. Again, they require keratin. They can eat this particular species can eat hard keratin as well as soft keratin. Your skin only has soft keratin, but your nail has soft, mostly hard keratin, and a little soft keratin. And there are some non-dermatophyte infections that can mimic this as well. We're not going to go down that plane though. So this is pretty severe. Mine doesn't look nearly this bad, but that's classic onychomycosis right there. The nail has gotten thick. This is distal subungual onychomycosis, when it affects the nail plate on the outside like this. We can see some longitudinal lines here too, can't we? These aren't Beau's lines, though. That's just from irritation from the bug eating keratin underneath. It gives it that appearance. Prevalence of this nail condition, about 10% of the population, definitely increased. I think mine popped up about around in my early 50s. It popped up. The prevalence increases with age. In people over 40, up to 20% of people can have this, and that goes up. People over 60 is probably getting close to 40%. One of the first signs, and this is true with me, my nails look fine, but I noticed my pinkies, my fifth nail plate, were getting thick, and pretty soon the toenail cutters didn't fit anymore. I'm like, what the heck? And then I knew, once I got this class, I knew and rebuilt this class from scratch. I knew exactly what it was. And it can become discolored. Mine really hasn't changed color at all, but they can become yellow, as we just saw. They can become painful in some people, especially people who are immunocompromised. But again, here's the moccasin type of Tinea Pedis. It's very common to be associated with that. You can see the nails are super thick and yellow looking, so these are all infected, patient immunocompromised. Now watch out for psoriasis of the nails, because it kind of looks like distal subungual onychomycosis, where there's a proximal subungual onychomycosis and a distal subungual onychomycosis, as we'll see. So it looks like it, but the key here is these pits. Onychomycosis will never do that. That's always psoriasis. Now, Reiter syndrome, which is similar to psoriasis, can do this as well. Irritant contact dermatitis occasionally, a trauma occasionally can mimic this as well. But psoriasis of the nail is the first differential diagnosis. And you look for that nail pitting again is the key to telling them apart. Psoriatic arthritis, again, can cause really bad disabling rheumatoid arthritis. It attacks and wrecks the joints. Remember we said last week it causes pencil in a cup. We went over that last week. But we said that diseases of the bone can go into the skin and into the nail. This is a patient who's got extreme dermatophytosis, and it's caused a hyperkeratosis of the nail bed, and you can see this is all skin. These are dead keratinocytes that have built up. Usually this modified epidermis of the nail bed is really slow. It doesn't the cells don't build up like this. All right, and yeah, sometimes you may have to take an x-ray to see what's going on. There's a really advanced case, hyperkeratosis here, subungual hyperkeratosis, very advanced case. This usually happens more in people who are immunocompromised, and there's just nothing to fight off the T rubrum here at all. So again, there's several different subtypes of onychomycosis. The one that affects the distal nail plate is the most common. That's called distal subungual under the nail onychomycosis. There's a proximal as well. Yeah, they can cause a really bad hyperkeratosis as well. Here's the one that popped up probably in the last year on me. And Stanford Dermatology can treat this. I'll show you what they're giving me for this. It takes about 8 months, she said, for it to work. These are really tough. The ones that are under the nail, she said, just forget it. As long as it doesn't bother you, it's not even worth treating. There's nothing you can do about it. So even if it develops out here in the lateral nail plate, it's still called a distal subungual onychomycosis. Right? So if it hits the distal nail plate, it's obviously distal subungual onychomycosis. But if it hits the lateral plate here, it's still considered a distal subungual onychomycosis. This region that effect is called the it's called the lateral nail fold. Lateral nail fold. The one out here, the fold underneath here, is the hyponychium. And there's our anatomy, lateral. Sometimes it's called the perinechium or lateral nail folds are right here. And then, yeah, we know the rest of this, right? Don't need to go over that again. Here's another really case in someone immunocompromised. I think this was an AIDS patient. And, distal subungual onychomycosis. and that can get painful. Now here's a proximal subungual onychomycosis, where the nail is pretty much spared here, although it can pretty soon take over the whole nail. It's still caused by a different strain of T. rubrum. Now this one, unlike the distal subungual onychomycosis, this one is commonly associated with something called paronychia. Paronychia. And that's just a cellulitis, an inflammation that has occurred here in the nail fold here. And that's not good. And it can abscess. Gross picture warning, so sensitive people get ready here. That's pretty gross looking. There's acute paronychia with cellulitis. All that red is staph, probably Staph aureus, that's gotten into the skin. You have to be careful. Antibiotics need to be started right away. Patient waited way too long because now he actually developed an abscess here as well. What's the treatment? Again, there's really no treatment for onychomycosis other than preventing it from destroying the entire nail. You can debris it if it's really, really bad. You could, I guess, pull the whole nail off if it gets painful and just live without a nail. But the prescription medications, the over-counter medications are a complete waste. Prescription medications, according to Stanford Dermatology, there's nothing they can do for this as well. You just can't get rid of it. Unless it becomes painful, then they can start debriding it. And if you do have the type that's where you get the hyperkeratosis, you do have to debris it because it'll take over the entire nail if you don't. There are some medications. Cislopyrox is the one that I'm using right now from Stanford. I just started it, so it hasn't made any effect. That's for the kind that has gotten in the lateral nail fold. She says that's much more treatable, but it takes about 8 months. Terbinafine is another one that she hasn't had much luck with. Asked her about that, but that's the classic one that might be on boards. Terbinafine, and yeah, there's some other ones, but terbinafine is probably the board one to know. Why is it difficult to treat? Well, the stratum corneum, the nail plate, and the stratum corneum of the nail bed, they're avascular. And so you can't get your body's immune system in there to attack and beat up the bug. So you have to rely on medication. Even though the nail plate is porous, we talked about how it's even more permeable to water anyway than your skin is. So you can get the medication, but medication alone is not going to do it. You have to have some white blood cells in there to help, and you can't do it. Here's the different types of onychomycosis. Superficial white onychomycosis we haven't talked about. The proximal and distal subungual onychomycosis, as we talked about. You can get a candida onychomycosis with a candida bug, but that's usually more in immunocompromised people. So the risk factors is anything that decreases your immune system's function, or anything that decreases circulation in the toes. So advancing age, you lose your immune system, you lose your circulation in your toes. Constantly wearing white or tight-fitting shoes cuts off the circulation. Injury to the nail. Diabetes. Chronic venous insufficiency from damage to deep valve veins can do the trick. Pad, anything. These are all going to decrease blood flow, and there'll be circulatory problems to the toes with these conditions. And then, of course, those who are immunocompromised, it can get really bad, right? How's the transmission? Well, it can be transmitted through nail clippings, wearing shoes. These dermatophytes produce spores that can live for up to 5 years in your carpet. They've been found to do that. So yeah, they can be spread a long time. So wash those feet, right? Don't use proper hygiene. When you're walking around, if you're in showers and sports and stuff, always wear flip-flops. Don't ever walk on these barefoot, right? If somebody has athlete's foot and there's a dirty area, athlete's foot or onychomycosis, you can pick that up really easy. Speaking about athlete's foot, let's talk about Tinea Pedis. Remember, that's the most common dermatophyte infection on the planet. It's often called athlete's foot or tinea of the foot. And it is a dermatophyte that gets hold of the palms of the hand, the soles of the feet, or the interdigital spaces, which is the webs of the toes and feet. It can also be on the side of the feet and hands. It's the moccasin distribution. And yep, it's same thing. It's caused by an invasion of a dermatophyte, namely T. rubrum again. A different species. There are other species that can cause Tinea Pedis as well, but T. rubrum, here's the other ones. I'm not going to test you on those. T. rubrum, you definitely need to know. There are some non-dermatophytes that can cause this, like Candida, although these are usually in immunocompromised people. And it's not uncommon if you have athlete's foot for you to have onychomycosis, so those two tend to go together. And you may have other dermatophytoses like Tinea manum, jock itch, Tinea crura. So if you have one, you can have another one. Fairly uncommon in children and females. For whatever reason, this tends to affect males. I don't know if they sweat more. They wear shoes and their feet sweat. I'm not sure what that is about. People in warm climates are more at risk. It targets areas that don't have sebaceous glands, so might have something to do with that, because of the palms and the soles and the interdigital spaces and around the outside of the feet. There's no sebaceous glands there. They're less common in people who don't wear shoes much, so kind of points that temperature is has something to do with this, or this getting a foothold, no pun intended. There's two basic presentations of these. There's moccasin, which is a distribution like a moccasin would be on the bottom of the foot, around the sides of the foot. And then there's interdigital, which is between the toes. You can certainly have both of those at the same time. There's classic moccasin, where it's affected the side of the feet and it's affected the bottom of the feet. Again, caused by T. rubrum usually. Here's an interdigital one, and it's spread onto the back of the foot, on the dorsum of the foot. So they actually have Tinea Pedis, interdigital Tinea Pedis, and they've developed Tinea corpus here. Remember, this is not Tinea manum. That Tinea manum is on the back of the hand. On the back of the foot is Tinea corpus. Okay, there's an interdigital picture there. Risk factors, again, pretty much the same as for the onychomycosis. Diabetes, people who are on immunosuppressant drugs, organ recipients, HIV, all of these people are immunocompromised. And there's some genetics there as well. And again, just like onychomycosis, it's picked up by spores that are left laying around in the carpet, on the floors in public bathrooms and things like that. Never walk in those places without protection. And no, the classic myth is if you wear white socks, it'll protect you from getting onychomycosis and Tinea Pedis. That has nothing to do. That's an old myth. So the socks I used to wear back in the 70s in football and track and stuff. They thought it would help prevent the spread of athlete's foot. Nothing to do with it. Tinea Pedis has a really strange clinical presentation in some people. It's called 2 feet and 1 hand syndrome. And so people can get 2 moccasin type Tinea Pedises, and then it affects 1 palm. Or they can get 1 sole and 2 palms. So you can get a mixture, and why it spares 1 digit is really strange, and we don't know the answer to that, but it's a common presentation. And so here's a moccasin Tinea Pedis, and you can't see as 1 palm is affected and 1 palm isn't. Here's another one where only one foot, the other foot is affected, one palm is affected with a moccasin type of tinea. And this is still called moccasin Tinea Pedis, even if it's on the hand. So that's called 2 feet and 1 hand. Strangely, even if it's in 2 hands and 1 foot, it's still called 2 feet and 1 hand syndrome, which is confusing. What about the treatment for Tinea Pedis? It's much more treatable, much more amenable to medication, topical antifungal creams, oral antifungal medication if it's a stubborn case of it. There's newer medications that are pretty good at getting rid of this. I don't have a problem with this one myself. Luliconazole, Luliconazole is a prescription only. It's 1%. It's an immuno-inhibitory derivative. It's very good at killing many different types of dermatophytes. This is pretty darn effective at getting rid of that bug. The over-counters aren't that bad. There's one called Lamisil, which is 1% terbinafine cream. It's not as strong as this prescription strength, though. Even though they both say 1%, it's not the same 1%. And yep, it's over the counter twice a day. You have to apply it. In one study, it showed that after 5 weeks of use, 88% of the people had significant reduction of their dermatophyte infection of the Tinea Pedis. Okay, see you guys later.